and thank you for being present for my talk on my study of glycemic restriction in cancer patients. I just want to introduce myself briefly. I'm a fellow of the Naturopathic Oncology Research Institute. Skipping 2 lines down, I'm president of the Naturopathic Cancer Society. Our profession does not interact much with oncology, so you may very well have never heard somebody speaking from my profession as a naturopathic physician, licensed in the state of Arizona, by the way. I'm from Tempe, Arizona. And some relevant things that I've written. That first line, I've published an article on this in Cancer Strategies Journal. Some of you have been to and lectured at the Healthy Medicine Academy conference that produces the Cancer Strategies Journal. For the last 8 years, I have focused on cancer patients and natural treatments for cancer. What I'd like to talk to you about, our study, is an ongoing study of cancer patients in a naturopathic cancer clinic, 317 adult patients over the last 7 years. We used intravenous nutrients as our treatment intervention and a dietary intervention, a rather simple one, as I will get to. I just want to start with the results first and then come back and explain. Regardless of the type of cancer or the stage, the sugar avoiders had more than 2 times the survival of the sugar eaters. Later, I'll define sugar. Of course, we all know what it is, but let's see how narrowly or broadly we define it a little bit later. And the bottom line was the sugar eaters had a 36% rate of remission, but the sugar avoiders a 90% rate of remission. Those were of the people who did our treatments, our intravenous nutrient treatments. You can see that sugar alone, the consumption of sugar, made a far bigger difference than anything that I went to the trouble of doing with intravenous nutrients. I'm going to explain all these in further detail as I go on. As a bit of background, the previous research on sugar and cancer had all been in animal studies, or they were fewer than 20 human subjects, or they were retrospective. But ours is the first interventional study that's long-term of cancer patients and sugar intake. It's the largest and longest of its kind, and as I say, it's ongoing. So we included everybody who came to us with a biopsy-proven cancer. Everybody who had a diagnosis of cancer and who stayed at least 2 weeks in our care. Anything less than 2 weeks I considered just visiting and not really involved with our treatments. And so we've never rejected patients for being too sick. I've literally seen metastases from head to foot. And nor have we rejected anybody for being too well. For example, a marathon runner with basal cell carcinoma recently resected. If it's biopsy-proven cancer, we also treat that person. And we did have to reject minors. Now, the study was controlled, but it was not randomized, as I don't have to lecture anybody here about medical ethics. You know very well, perhaps better than I do, that with life-threatening illnesses, the patient must be given as much information as possible regarding every available feasible treatment protocol, and that has a reasonable chance of success in their case. So we had to allow them to make those choices with no threats, no coercion, not even duress. I tell my patients I am not a hard sell person. You do as you please. It's an outpatient clinic. I don't ask them to sign up for any program. Whether I see them again next week is up to them. And if I don't, that's okay. But so it's not a hard sell clinic. In other words, they make their choices not only at the beginning, but as they go through the treatment. So the patients were not randomized. They chose to have the natural treatments or not. If they did choose the natural treatments, they were included in the study in the 317. They did choose to have chemotherapy or not. Some come to us having chosen not to have chemotherapy. I have always respected that choice, but I've always told the patient, whether you choose to have chemotherapy or not, whether you choose to have radiation or not, I owe you my best efforts, and I will give you my best efforts. So it was their choice. And this is the variable that I paid attention to in the study. They chose to follow our recommendation to avoid sweetened foods or not. The single independent variable, that avoidance of sweetened food, that was the variable in as much as you can control other variables in an outpatient clinic. We know that in an outpatient clinic, there are a variety of environmental influences. Somebody lives under a smokestack and somebody else lives on a farm and somebody else, well, anyway, they come to you with their history, their baggage, their genetic baggage, as we say colloquially. Um, so actually, Johns Hopkins University established a compliance being treated as a dichotomous variable. So the participants were considered to be either compliant or non-compliant, and that was an acceptable type of controlled variable in a controlled study. Normally a controlled study would have randomization, and so with the emphasis on patient choice, we couldn't do that. And that's an article that was also described, compliance as being the variable, was described in the Clinical Trials Handbook. All the patients, so here's what we studied. All the patients in the study received the recommended intravenous nutrients chosen for anti-neoplastic effect, but what differed was how those who received those IV treatments and avoided sugar differed from those who had those same treatments and consumed sugar. That was the difference. Now, let's go back to when we started the study, 2006, and the political climate at the time, not very different from the climate now. Nobody questioned, well, let's say few people questioned the authority of the oncologist in most matters, or the oncology mainstream, in most matters related to cancer. And oncologists routinely told their cancer patients, and still tell them, to eat all the desserts that they can eat. Your job is to keep your weight up. Chemotherapy is going to make you skinny, maybe even skeletal. So you have to push it in the opposite direction by fattening yourself up as much as you can. But we had to rebel against that because that diet was toxic. Now, how did I know that was toxic? It wasn't me who came up with it. Of course, it was many people before me who said, how widespread is the problem of sugar damage to cancer patients? And I would like to make my case to you over the next 7 or 8 slides or so. You will see evidence that in various types of cancer, sugar has worsened the outcome. Sugar worsened the outcome in pancreatic cancer. It worsened the outcome in breast cancer, prostate cancer, gastric cancer, colorectal cancer, ovarian cancer, endometrial cancer, liver and biliary tract cancers. Ladies and gentlemen of the jury, I present to you my case that sugar is no darn good when it comes to cancer, or at least for my cancer patients. So I had to ask this question. Is it possible, just maybe, that sugar worsens all cancers? Well, I don't know, but I asked the patients to please avoid it. So, okay, let's go back to the definition, which I think we'll probably all agree on. Sugar is the colloquial common name for sucrose, and we know that that is the disaccharide of glucose and fructose. Here are the 2 monosaccharides with the oxygen bond between forming the disaccharide, as you know. Sucrose is, as you know, 50% fructose and glucose, but high fructose corn syrup has that margin 5% extra fructose. Neurobiologist Stephen Guenet has graphed our consumption of sugar in the United States, pounds per person per year, over the years from 1820 to 2005, and he showed that, this graph, which actually has really increased quite linearly, so that all of the data points are really not very far from a line of that slope. It's increased quite a bit. Now, if that's projected into the future, by the year 2606, I guess we could be expected to have 100% sugar in our diet. Of course, I think intervening factors will probably affect that graph by the time we get to that point. Okay, and that's his research. And that's more of his research. And then, when you eat sugar, you like it, you crave it, and then what happens? The blood sugar levels spike, and at that time, cancer has a resource of sugar available to it. The timing of a PET scan is calculated so that the sugar will be at a maximum. But also, we know that when you eat sugar, the pancreas secretes insulin. Insulin delivers sugar to cancer and other cells, but particularly to the cancer, that insulin being a co-conspirator here, I suppose. Anyway, we know that, and I know this is all review for you, so pardon the review. I just want to go through it very quickly. Cancer cells use fermentation, of course, rather than oxidative phosphorylation as a metabolic process, but we know that's very inefficient. For much sugar coming in, there's very little energy, ATP, coming out. So then cancer is then a very hungry engine for much fuel, the fuel of sugar. And then, of course, it meets its own fermentative needs. But Stephanie Seneff, PhD, wrote Cancer to the Rescue, a very interesting article in that the cancer actually serves some function. That is, it takes vast amounts of sugar in order to produce lactic acid. Not that she or I am advocating that it exists for that purpose, but anyway, it seems to perform that function. We're all familiar with what a PET looks like. You see here a very widely metastasized cancer. And as you know that the lesions that you see throughout the skeleton and the soft tissue, those lesions represent cancer. But I want to look a little bit more close. Oh, well, first let me look at normal PET images. You know, in a normal PET, you and I look like this, I imagine. The brain is black, and of course that's because, you know, glucose is the preferred fuel for the brain. The bladder is black because the radioactive glucose that's been injected has yet to be urinated out. And but let's look at a close-up. This is a close-up of the liver. Not only do we see that the lesions, the tumorous lesions, take up the sugar, but to such an extent and so reliably that the rough outline of the tumor can be seen. That is, the contrast between the sugar uptake in the cancerous tissue and the normal tissue is so very stark that not only we can say it's somewhere around there, but we can see the outlines. Of course, this is not nearly as crisp as what you're going to see with a CT on a PET-CT fusion, you know, with the CT giving us the crisp precision of the image. Still, the PET tells quite a bit. Okay, let's go back to our study, please. In our study, we asked patients to avoid the following: sugar, honey, maple syrup, corn syrup, high fructose corn syrup, alcohol sugars, plant nectars, and yes, even fruit juice. The reason being is that we know that all of these have been able to raise blood sugar and to even spike it. However, we did allow stevia as a sweetener. I don't know if you're familiar with this plant. Stevia rebaudiana has been used traditionally in Paraguay and Brazil for many years, but it's been found to grow all the way up through as far as Canada, and that is not known to increase blood sugar. So we told them they could eat stevia as a sweetener, and we even post recipes with stevia on our bulletin boards in our clinic. And let's see. So, okay, let's talk about the rest of the diet. Now, cancer patients often ask me, well, what else am I supposed to eat? It's not just about sugar, is it? Aren't I supposed to have other restrictions? We told them vegetables, fruits, whole grains, dairy, eggs, and yes, we told them meats, poultry, and seafood, as much whole, natural food as possible, as little processed food as possible. When asked, well, what kind of beef should I eat if I eat beef? Okay, please try to go for the, grass-fed, the free-range, the organic. That would be best. But I didn't really, none of our clinicians really emphasized that too much because, well, so when they asked, should I be vegan? Fine. Vegetarian? Fine. Omnivore? Fine. And ketogenic? Even better. You're aware of the ketogenic diet? Well, we had to keep it simple, so the patients would not forget or neglect that one thing. I had the misfortune early on when I practiced of having a patient come to me and saying, well, I ate everything organic, and yes, I got the grass-fed beef, and oh yeah, I forgot, and I had some dessert. And I thought, uh-oh, that's the thing that we need to avoid, the dessert. And so after that, I said, eat anything you want. Just don't eat the desserts. No soda, no dessert, no cookies, none of that stuff that, anything that's sweetened with other than stevia. So that was not a popular idea. Chemotherapy rooms had plenty of sweets to offer cancer patients because of the need to keep the weight up, and they still do. So what happens if you avoid not only sugar, but most carbohydrates? And we know that many cancer patients have benefited from a ketogenic diet, where the fat outweighs the protein plus carbohydrates 4-to-1 is a more commonly accepted definition of the ketogenic diet, but there are other variations on that. So glioblastoma is probably the one that you're most familiar with as having benefited from a ketogenic diet. I'm sure you've read about that. But there are others. Prostate cancer, gastric cancer, lung cancer have benefited from a ketogenic diet. I really could be listing quite a few more studies up there. But let me get back to my study. 29 patients, as we say colloquially, fell off the wagon. That is, they ate sweets. So that was the non-compliant cohort. 20 patients died while still exclusively in our care. I say that our treatments bounced off them as if our treatments didn't exist, had no beneficial effect. 12 more died while still in our care, but had eaten sweets. 16 patients in remission came out of remission. 5 of those are now back in remission, but 4 of those 16 had eaten sweets. So, okay, because it's an outpatient clinic where everybody gets to do whatever they want, there is chaos and anarchy reigning at my clinic. Among the patients, anyway. The rest of us are pretty well disciplined. Okay, so here's all the things that could have happened. Remission, or they died while still only in our care, or there was iatrogenic death, or of those who left before finishing treatment, the number who died after leaving. Now, DDD is where I'm calling death after dietary dispute. That's where they ate sugar, even though I asked them not to, and then they died. Okay, so that's death after dietary dispute. Some are still being treated, not yet in remission. Some, I have no current information. I call our patients every summer, and I ask them 3 questions, just to keep it short and simple. How are you feeling? And are you still exercising? And are you still able to avoid sweeteners? I keep it short because these are usually unexpected calls, and I also call them every year because I feel that when it comes to remission in cancer, time tells the most truth. If I call somebody year after year and they're still playing golf, or they're still retired, or they're still working at their job, then I'm pretty confident that they're doing okay. I don't say you're going to have every cubic centimeter of your body imaged again, because of course there would be zero compliance. And then the last category, waiting to know status or conflicting information. Very often you and I have seen ambiguous results, say, on imaging. And so we're waiting for that to get clarified in some cases. Okay, that was the non-compliant cohort. Let me go forward a few slides because this is a bunch of numbers that can be distilled down to here. For all of the cancer patients, that when I call them steadfast, I mean they were steadfast in our treatments. Oh, I should be using this instead of pointing. The steadfast, I meant our intravenous nutrient treatments. And this is whether they continued to eat sugar or whether they had given it up. Of the total of 183 patients who were steadfast, out of that big number of 317, of those 151 went into remission and 32 died. That included the death after dietary dispute. Now, the sweet eaters, here's the non-compliant cohort. Of the 25 patients treated until remission or death, 16 died. Only 9 went into remission. That's only a 36% rate of remission. That speaks to, I guess, the value of our treatments. The steadfast patients, steadfast with IV nutrient treatments by stage of cancer, but avoided sweets. Now, 142 of those went into remission, of the 158 who were steadfast with IV nutrients. So then we got 90%. So you see the sugar made a far more dramatic difference than anything else that happened to them. Oh, by the way, I have to remind you that some of these people got chemotherapy during our treatments. Some had chemo before our treatments. Same with radiation. And same with surgery. So that's the summary in a nutshell. I already talked about that. Okay. And I would like to conclude with this. Consuming sweetened foods made a difference in the patient outcome across both all stages and all types of cancer among the patients presenting to our clinic. And my request to you is, if you have cancer or know somebody who has cancer, I would like you to seriously consider the evidence here and decide for yourself if consuming sweets or continuing to do so is worth the risk to your health. But for those of you who are healthcare providers, I cannot ask you strongly enough to please consider this advice for your cancer patients. I think you will save lives if you just do this and not much else. Or not much else, but anything else, any other intervention. And I would like to suggest that you get to know stevia, but it does taste bitter in excess, so please don't use too much. And that's pretty much all I wanted to tell you. Thank you.
As we are running a little late for the coffee that you need, desperate, I will limit the 2 questions, and I will encourage you to interact with all our speakers during the coffee break and beyond.
Room 4 over. Now, what do you mean?
Okay.
Question?
I thought that was fascinating. It reminded me of the results of the famous Wisconsin monkey study, you know, where they starved, well, not starved, but had a restricted diet for some monkeys and a very rich diet for the other monkeys. And the ones on the restricted diet lived much longer. The ones on the very rich diet, with a lot of sugar in it, they tended to die of either cancer or diabetes.
Yes. Yeah. Yes. I remember. Thank you. Yes, sir.
So, very short question. Sweet, is it a promoter of cancer, or only after cancer you should stop taking sweet?
I'm sorry. I didn't completely understand the question.
Is it promoting cancer? You told something against sweet.
Yes.
Is it a promoter of cancer, or after you have the cancer, you should stop taking sweet?
I understand your question now. Thank you. I don't know if sugar contributes to causing cancer. I cannot say. I don't meet the people before they get the cancer, only after. And so it is very difficult to say. Perhaps when cancer is... Okay, for all the people who are diagnosed with cancer now, you know that's a tip of an iceberg. And the vast iceberg under the water is all those who have as yet undetectable cancer in their bodies. Is it possible that those cancer cells, those early microtumors, is it possible they are fed by cancer? I think likely. I don't know if sugar, though, causes cancer. That is a very good question.
Thank you.
You're welcome.
Just okay, very nice presentation. Very quick couple of questions. You know, the field of the feeding the tumor by sugar has been debating for a long time. And one of the questions I have is, how do you monitor this patient that they are avoiding the sugar? I can tell you I'm avoiding sugar while I'm doing something else. It's been shown several times on the survey, 24 hours recall, even the phone call. The patient or the subject, they can exaggerate one way or the other way.
You are so right. I am relying on the honesty of patients self-reporting, and nobody is policing this data, and of course nobody can. I mean, to go to their houses and inspect their cupboards, of course, well, it's just out of the realm of even civil liberties. But here's my one measure that I can take against that. I adopt from the very beginning a completely non-judgmental attitude toward the patients, and then when they tell me, "You want me to give up my chocolate? How can I give up my chocolate?" I say, "Don't worry, I understand. I know it's difficult. I've been there. I don't eat it either. And I know it's difficult not to do this. So let me work with you. Because if you are still eating sugar, I consider it my fault that I have not yet given you satisfactory substitutes. So let's work on recipes. If it's that you need sugar in your coffee, let's work on what we're going to do with your coffee to make it taste good. If it's that you need chocolate, let me tell you about a chocolate that's 85% or higher, so that you can only have 1 or 2 grams of sugar in a small square."
Just one last comment is I truly believe on stevia, but the cancer experiment has not been done on stevia, so it's still a matter of question is how is reacting for the cancer prevention or even treatment, stevia.
It seems that they are doing well with the stevia. So this is in vivo, and we don't have the data that we very desperately need in vitro. I would really like to see that. And yeah, this is just in its infancy, this kind of study.